Hi, this is Bob Harrington on the Heart.org and Medscape Cardiology. We have had a series of discussions lately, largely specifically focused on the world of cardiovascular medicine and science. And today I thought I'd go back to a topic on which we've discussed in the past that has really generated, I think, a lot of interest in the cardiovascular community, and that is where we're at with the Affordable Care Act, or ACA, several years later after both its passage and then ultimately its implementation. And this is a topic which gets a variety of responses in the medical community as we talk about issues of the ACA and how it planned to increase access to uninsured Americans, how it was asking healthcare systems to think about the healthcare providing value in terms of improved patient outcomes as opposed to just thinking of it as providing a service, has all generated a variety of opinions in the community on different ends of how people view that, meaning as either a good or a bad thing. Obviously, the politics of all of this have been complicated, and trying to keep our focus on what we as medical professionals are trying to do, which is to deliver excellent and optimal health care to our patients, versus how potentially some of the politicians and policymakers have viewed health care, which is as a major societal both resource and expense. You can understand then why perhaps there's been some tensions in these conversations. Well, today I'm especially pleased because I think we have a guest who can really provide us some insights into how the ACA was formulated, how it rolled out, and from the position of a former insider, if you will, provide us some reflections on where he thinks it is a couple years later. So I'm really pleased to have my longtime friend and colleague, Dr. Bob Kocher, on the phone with us today. Bob is a partner at Venrock in Northern California. He is also a consulting professor at Stanford University, and he is a former special assistant to the President for Healthcare and Economic Policy working within the White House. So, Bob, thanks for joining us here today on Medscape Cardiology.
Thank you very much, Bob, for having me. It's a pleasure to talk with you, and I look forward to our conversation.
Well, Bob, before we sort of wind up in the White House and you provide us an insider's look at how the ACA was formulated, let's talk a little bit about your background, because you're trained in internal medicine and were on your way to a what I'll call traditional career as an academic physician scientist, and you moved into a different world. Why don't you walk us through that a little bit? I think it will give our listeners some perspective on how you ended up in the White House.
I've been fortunate to have a series of mentors along the way that have allowed me to have a fascinating career, but one that certainly I couldn't have planned. And it really stems from my time as a resident at Beth Israel Deaconess in Boston and my observations that hospitals didn't work right. And it didn't make sense to me at the time that I was a resident and then early on a fellow. The least experienced person in the hospital was making so many choices about what happened to patients and could affect the economics to such an extent for a hospital, could choose treatments that we thought were interesting and evidence-based but maybe not right. And that there were so few controls, oversight, mentorship, and management going on. And we all know there's bottlenecks in a hospital, like EDs not being able to move patients and not being able to discharge patients and not being able to get your procedures done. And just the management confused me. And I thought I could run a hospital better than the way they were being run at the time.
I think all of our residents think that, but not many of them go on to do what you did.
Most people don't knock on the CEO of the hospital's door and ask them how to get their job, which I did. And after the smirk of Jim Mongan's face went away, he said, well, doctors don't know anything about math and management and, really don't know anything. And I needed to go get a business degree, was his advice to me if I wanted to ever run a hospital someday. But I'm sure he thought I would just go away. I came back 2 days later after my wife nixed me getting more schooling and said, well, what's plan B? And he said, well, you need to go to McKinsey and learn math because you have no idea what you're talking about. So I did that. So I quit the hospital.
So when did you quit? You were a fellow when you quit.
So I just started a fellowship at Dana-Farber to go be what I thought would be a bone marrow transplant doctor.
And his perspective was, which was the right perspective, is that you needed some quantitative analytical skills and a way of approaching problems that was different than a science hypothesis-based way of viewing the world. Is that a fair assessment?
Yeah, because as a doctor, you have a lot of granularity about how to make things better from a doctor-patient perspective, but you don't understand much, or at least I didn't, about all the other forces that work on a hospital and on the healthcare system. So the payers and the coding and the billing and the EHR and data stuff and the labor cost management dilemmas and the capital budget planning and the competitive marketplace, frankly, for patients and doctors, how the research infrastructure fits in, the role of teaching in medical schools, all that stuff. And so you need to learn that, I think, to be an effective leader of a healthcare organization. And you can learn it certainly by doing it the traditional way, through a series of roles as a doctor leader. But for me, learning business and economics and business strategy and getting a glimpse into 30 or 40 other health systems helped a lot.
Brilliant move. You decide to go to McKinsey. Most people know that it has a consulting arm to it. Why don't you let people know exactly what they do in the healthcare world and kind of summarize your time there, Bob, because I do want to jump up to how you ended up in the White House.
Sure. So let me walk you through what McKinsey is. So McKinsey is a management consulting firm that serves very large companies, typically the Fortune 1000, on questions of how can the business improve its performance economically, how can businesses grow faster, and how can businesses improve the way they operate themselves. And so McKinsey takes teams of people, often young people out of graduate programs, whether they're doctors, lawyers, MBAs, and staffs them on projects for 6 weeks to 6 months at companies to help solve problems. And McKinsey likes to have us all be generalists and help expose you to different business sectors so that you bring fresh eyes and can question assumptions. And I came to McKinsey and said, I don't want to be a generalist. I want to learn how to run a hospital someday. And I was told by a guy who runs a hospital, this is what I need to do. And they cringed and said, well, that's not what we do. We want you to learn business in a general sense. And so they send you to a mini MBA course, in my case, to teach you the basics of economics and marketing and how to use Excel, how to use PowerPoint. They teach you how to work on teams, which are different than the medical teams you work on in the sense that you have a series of peers that are breaking up problems into pieces and then putting them back together. Teach you how to influence clients. So you're often, a young and experienced person dealing with somebody much older than you who thinks they know a lot more than you. So you have to learn how to interact with them to help them gain confidence that you're going to have something useful to say. And then you get exposed to a whole bunch of organizations. And I was very blessed that when I joined McKinsey was about the same time that hospitals were increasingly interested in learning more about how to have growth strategies and how to improve their economic performance and answer questions like, should we hire doctors and build out new centers? Should we enter into risk contract? How will we improve quality, and would that be a good business move? And so my first projects were at academic hospitals who were often trying to reduce mortality for different diseases and use that as a way to attract more patients. I then told McKinsey that I only wanted to do hospital stuff. And while that's not their model, I said I do it anywhere on the planet. And so with that kind of geographic flexibility, they then sent me to the Middle East for a year, where I worked in Qatar, Saudi Arabia, Dubai. Then I worked in India and Singapore. Then I did a stint in the UK and Germany and France and Denmark. Then I went to Canada and interspersed some projects in Mexico in the U.S. And so I got this very interesting global view of how hospitals work. And I was surprised that across the planet, hospitals basically are similar to the U.S. They struggle with getting doctors to follow directions, to show up on time. We all struggle with getting our patients discharged. They all have flow problems of moving patients, from the ED into the units and in and out of their ICUs. We all struggle with medication safety and hand washing. That on Earth, hospitals all have these characteristics. And that led me to ask a series of questions. One is, why? Are hospital CEOs on Earth all just incompetent? Could that be it? Are doctors unmanageable? Are patients just so complicated that you can't build systems that work better? And sort of what's going on? And so McKinsey has a think tank called McKinsey Global Institute. And at that time, they had nobody analyzing healthcare. And so I reached out to the think tank and said, hey, I really like to understand healthcare economics and understand globally why aren't hospitals better? And why can't any country get this right? And they said, sure. And so then I shifted my role at McKinsey to predominantly lead their economics think tank for the next several years. And that led us to do a whole bunch of work on economic incentives across the world, on trying to calculate who's getting their money's worth and what are differences in productivity of labor, of healthcare outcomes, what are different approaches you could use to drive better patient care. And then that led me down a path towards looking at the U.S. more closely and healthcare policy.
So this is fascinating because you start life as a working doctor and then you move towards trying to understand delivery from a global perspective, and you realize that there's all these commonalities that we share in some of the challenges of delivering health care to our populations, that makes you then think, might there be system issues here? Might we better align the incentives? Might we better look at ways to generate value? And that gets you somehow to the White House. So let's talk about that. You go to the White House, and did you go as a special assistant to the president, or did you have some other role before you migrated to that role?
I went as a special assistant to the president for healthcare and economic policy. The way I got to the White House was while at McKinsey, we did an interesting study of the U.S. healthcare system. This was in 2006. If you recall, 2006, the U.S. healthcare system, much like today, spent more than any other country in the world. There were widespread concerns that we weren't getting our money's worth. Doctors were frustrated by the way the system was increasingly having them have to see more patients and not get paid more necessarily. There was lots of concerns about beginning to measure outcomes and trying to ascertain what's evidence-based care and what works. Hospitals were, broadly speaking, struggling, and health insurance costs were growing far faster than wages. And so we did a report at that time to try to figure out, of the $2.7 trillion that we were spending in 2006, where all the money went and who made it all and why were they making the money. And believe it or not, that hadn't been done up until that point in time, and it was hard to do. So we took the U.S. healthcare spending and we literally took every dollar and said, well, who got it? And how did it flow through the system from a health plan or a premium to often a hospital or a doctor to a medical device company to a drug company to post-acute care people, and cut it every way you could think of. So kind of by disease, by system player, by outcome. And what we found was a variety of shocking things. One is we quantified in a bottoms-up way the widely spread notion that we waste about a third of our spending. We kind of showed you where the waste is in the healthcare system. We showed you who's making money, and in many cases, they're making less money than you think. We dispelled a bunch of myths around performance in the healthcare system, and that was the fact base that both the Obama campaign, the Hillary Clinton campaign, and the McCain campaign used to formulate a lot of their broad healthcare policies. And so as part of being the author of that study, I got to help brief and educate the policymakers in the various campaigns as well as in the House and the Senate about sort of how the system works, because we all needed some sort of set of facts to base how you'd want to reform the system.
So at that point, Bob, did it become a little bit of be careful what you wish for? Because you understood the details of this, I suspect that somebody somewhere said, you've dissected this, now why don't you come offer some solutions?
That was pretty much how the conversation went. So you've written the big report showing us where all the problems are, so come fix them. And that seemed super attractive to come and try to make the system better. We all hope to do that, I'm sure, every day. And so it took me 2 seconds to say, of course, I'm happy to. And then naively, I'm like, well, and the answers are sort of obvious. You kind of lay out, well, you change how you pay, you cover everybody, you start paying people to make you healthier and reward outcomes.
You start worrying about outcomes rather than procedures. You start linking reimbursement to incentives for how patients do, but now you've thrown the system completely on its head.
Yeah, so it takes about 2 weeks on a whiteboard to get Republicans and Democrats and smart people, I think, from, frankly, most perspectives, to broadly agree on what to do. And then everything falls apart because you have to convince a Congress and a functioning health system that this is a good idea to change. And that's much harder than one would ever imagine in a fascinating learning experience.
I'm going to try to get at some of the things that our listeners might really want to get that insider's view. What were the key goals behind the ACA, and what did you learn about actually trying to get something done in Washington?
Sure. So the key goals of the ACA were 3 things, and 3 things that my Republican friends and my Democrat friends, I think we all agree on. The first one is we ought to be able to spend our money more productively in the U.S. healthcare system to get more value per dollar. So we spend today $3.1 trillion. I think there's a widely spread view by Democrats and Republicans that we spend enough money to have the best healthcare system on the planet, that we should treat our patients always skillfully with their diseases and do a great job on delivering outcomes consistently across America without regard to geography and race and what health system you happen to pop into, number one. Number 2, that we should be able to provide excellent healthcare to all Americans, that there shouldn't be sort of the haves and have-nots here, that which employer you work for shouldn't predict if you're going to get to have great health care choices or not, and that Medicare and Medicaid as programs should work well for people. and that you shouldn't go bankrupt as an American having to manage your healthcare costs. Or, God forbid, if you have a chronic disease, you shouldn't sort of therefore not be able to live well. And number three, that we are the most innovative country on the earth when it comes to inventing therapies and delivering extraordinary care. And so we should be better at pushing out the type of work, Bob, that you've done in your life around the cardiovascular trials more quickly, so that patients who don't happen to walk into an academic medical center or live in certain areas have access to evidence-based care faster, and that we can adopt new things quicker. And we can also stop doing things that don't work, so that we could improve quality and basic things like medication errors and hand washing and hospital-acquired infections and readmissions, so that we can close the loop here so that we don't have subpar outcomes that are avoidable. Those were the three goals. And the approach was, broadly speaking, that we should be able to take inefficient spending or waste as a major lever to fund the premiums of people who we newly expand coverage to, and that, by the way, by averting complications, that we're going to save some money too. That should make the system work better and improve outcomes.
So all mum and apple pie up till now.
It sounds good.
As you said, I mean, this is where there's vast areas of agreement. We want more value. We want all of us to have access, and we want to roll out the things that work and roll back the things that don't work, and package all of this up and deliver it to 300-plus million people. I can't imagine that there's anybody that disagrees with that.
Yeah, unfortunately, about half of America starts to unravel after that level of description. Today, the healthcare system's waste is income to a doctor or a hospital or a medical device company or a pharma company or a health plan. So when I cut waste, it's very popular to cut waste until it's your money.
Right.
And then people get really upset. And so even things like hospital-acquired infections, the line infections that sometimes happen in hospitals, we wanted to stop paying for those, because perversely, as a hospital, you could make more money in many cases from causing the infection than from not. And that seemed like a bad incentive, so we tried to change that. But hospitals, of course, clamored, saying, well, wait a minute, we don't want to lose that revenue. Maybe we don't want the infection, but we want the revenue, so don't cut the revenue. And so you can imagine that it gets ugly.
And it did, and it remains a bit ugly. But in the last couple of minutes, Bob, let me try to get at two things. When did you leave the White House? You left the White House before the actual rollout. So what did you think as a former insider at the rollout? And when I say the rollout, what I really mean is, the ability to sign up in the exchanges for health insurance. Not done well initially, but then did sort of regain its footing, and by all accounts looks to have been done reasonably well.
Sure. So I left the White House after the second year of the administration, so at the end of 2010. What I would say is that the skills required to pass a large law like the Affordable Care Act are specialized and unique, and you have to be, world-class at managing a legislative process to pass a law. To implement a law, you need world-class skills on management and operations and strategy and program execution. And the people who are the world's best people at passing legislation, have no experience in how you actually implement a complicated program like this. And so there was a variety of us on the economic team who were, recommending that there be a lot more independent and sort of private sector-oriented people running the implementation, which perhaps would have led to a more smooth rollout, because the skills are so different. Managing thousands of people to build websites and do marketing and set up CRM tools to manage, people who want to buy health insurance, and to do all the partnering you have to do to make that work is totally different from writing regulations and getting Congress to do stuff. And so
that's a very articulate way of putting it, and I think that ultimately, certainly my view as an outsider was that that's what happened, that the private sector, in large part the tech private sector from the Silicon Valley area, came in and lent their skills to organize this.
A force of nature named Todd Park sort of came and saved the day.
Yep.
With a whole bunch of friends from Silicon Valley who, were startlingly able to do what $500 million and, armies of people from contractors couldn't do in like 6 weeks. So it shows you when you get the right people in the right jobs, you can really make things work well. But it's really hard in Washington to sort of tell people who are, the world's best people at passing legislation that they're not going to be the world's best CEOs of managing implementation.
So let me ask you, Bob, in the last minute to reflect on two things. You're in a new position working in the venture community. You also have an affiliation with our university, and for that we're grateful. Give me your worldview now that you're looking at it as a funder of innovation, and give me your view as you look at a changing composition of the Congress. What's going to happen to the ACA? Are we in danger of having this rolled back? Are we going to continue as is? What do you see for the next year or two? So your perspective on your current position and what you see for the next year or two.
Sure. So I think that for the rest of our lives, the central issue in U.S. healthcare is going to be affordability. And that's going to be affordability for patients to pay for their premiums and their copays and their coinsurance, and their companies who are often paying the majority of them, but also the public sector who is paying for Medicare and Medicaid. And that whether there's Republicans or Democrats in charge, that at the end of the day, people will be actively managing U.S. healthcare to make sure that the costs do not grow as fast as they grew before the ACA. Since the ACA, for a variety of reasons, including the ACA, costs are growing more slowly, and that's making the federal budget and state budgets and employer budgets much more manageable. And so there will be downward pressure on costs forever because with demographics of baby boomers aging into Medicare, healthcare costs will rise because old people will have more healthcare costs than young people. And so we will have lots of federal attention to make sure that we manage costs well. And that's going to drive policymaking. And so I believe that the Affordable Care Act will remain because it appears to be helpful in the cost management equation, and that Republicans may choose to add more cost controls and Democrats may choose to add more cost controls, but fundamentally that the law itself will not be taken away because going back to fee-for-service and 5% year-on-year cost growth is going to be untenable to anybody.
It's not sustainable for us as a country. Now give me your perspective as somebody who's entered the venture community and is thinking about innovation, particularly in the technology healthcare space. How do you wrap that into your former life?
Yeah, so my former life helped me understand, from the point of view of a doctor and a patient, and from the point of view of a hospital or a health plan, and from the point of view of a public sector regulator who's trying to make the health system work, where there's chances to do things better. And today what I get to do is I help work with companies who want to try to make healthcare better, and I help point them to what I think are the large problems that we can solve today, and then get to have a front row seat, helping to guide them through the, test it and scale it and refine it and grow it into real companies. And what's exciting is that the mixture of the Affordable Care Act, demographics, and the ability to build software companies much more efficiently than we ever have before is attracting more people to want to go attack these kinds of problems. And so it's a lot more fertile ground than it had been in the past. I mean, people used to call healthcare IT investing Siberia because you couldn't attract talent to do it. You couldn't get hospitals to buy it, and it took forever to make the companies. And Athena Health was really the first one to kind of break the ice here, but it took them 13 years to sort of go from managing an OB-GYN practice in San Diego to building a big software company. And now you're seeing some success stories like companies like Castled Health that do it in 5 or 6 years, and One Medical and Health Catalyst and Grand Rounds Health that are all being able to grow faster and prove that there's sort of a path, and also some successful non-healthcare CEOs coming in. So it's become a lot more fun and a lot easier to make healthcare companies. And the Affordable Care Act incentive changes help shine light on different spots where you can now, invent new things.
So, Bob, I really appreciate what you've done here, which is you've taken your sort of personal journey through healthcare to help us all, I think, understand where we are as a country thinking about providing high-value healthcare to all of our fellow citizens. And I like how you've talked about your movement from academic medicine to the private sector, to the public sector, back to the private sector, and you've had a great seat. And I appreciate your willingness to maybe peel back a little bit of the onion so that we can all take a look at what's been going on inside. So I want to thank my guest, Bob Kocher, who is a physician trained in the Boston Harvard system. Currently, he is a partner at Venrock. He's a consulting professor at Stanford. And for the purposes of this discussion, we've learned a lot from his former role as special assistant to the president for healthcare and economic policy. So, Bob, thanks again for joining us here on Medscape Cardiology.
Thank you very much.